Hello, everyone, and welcome to today's conference session. Also ask that speakers verbally disclose any relevant financial relationships they may have at the beginning of their talk. I'd now like to introduce Steve Gnatz, Azlan Tariq, Ashir Wahab. Over to you, Steve.
Thank you for that introduction. And we're going to spend the next hour to hour and a half or so telling you a little bit about the role of the physiatrist in the skilled nursing facilities. So without any further ado, let me go ahead. I think I've got control of the slides here. As mentioned, I'm Dr. Steve Gnatz. I'm the Chief Medical Officer for Integrated Rehab Consultants, the largest group of physiatrists practicing rehab and skilled nursing facilities in the country. Speaker disclosures, other than the fact that I am Chief Medical Officer for Integrated Rehab Consultants and I'm employed by them, I have no other financial disclosures. Our outline and our goals for today's session are to describe the role of the physiatrist in the skilled nursing facility environment, to demonstrate, for you to be able to demonstrate proficiency in identifying the value of physiatric consultation in the skilled nursing facility, and also for you to be able to list common challenges and opportunities in working with a physiatrist in the skilled nursing facility environment, and for you to be able to demonstrate proficiency with the trends affecting rehabilitation in a skilled nursing facility environment. What is a physiatrist? A physiatrist is a medical doctor specializing in physical medicine and rehabilitation, or PM&R. So PM&R is a medical specialty concerned with the diagnosis, evaluation, and management of people of all ages with physical and or cognitive impairments and disabilities, or potential for the same. So not always are people going to have these, but as I'll tell you, we're all only temporarily able-bodied, as you know, maybe the recent examples of our pandemic have pointed out. So people throughout their life will have some type of impairment or disability, particularly as they age. PM&R training emphasizes the diagnosis and treatment of patients with painful or functionally limiting conditions, management of comorbidities and co-impairments to those conditions, also diagnostic and therapeutic injection procedures, electrodiagnostic medicine as part of our training, and consideration of preventing complications, secondary complications of disability. Why would you need a physiatrist? Well, in an inpatient rehabilitation facility in America, American Rehabilitation Medicine, which really grew up in inpatient rehabilitation facilities, or IRFs, I'll refer to them as IRFs, the physiatrist is usually the attending physician for a patient undergoing rehabilitation. In fact, it's mandated by CMS that a rehabilitation physician be involved in both the admission and ongoing stay requirements of someone in an inpatient rehabilitation facility. However, those of us practicing in a skilled nursing facility environment, we're usually a medical consultant. So SNF rehab carries no mandate for a rehabilitation physician to be involved in the coordination of care of the patient. So in a SNF, we're a medical consultant. You, as the medical director of the consultant, then consult us to help coordinate the skilled nursing facility rehabilitation program for your patient. We help direct the rehab team and participate in rehab team meetings. We can recommend medication changes and address specific issues such as pain, spasticity, bowel and bladder function, things like that. And we can recommend diagnostic studies as needed to work up particular problems. And we can recommend appropriate durable medical equipment, working along with the therapist recommendations for those types of durable medical equipment that the patient might, say, go home with or even use in the skilled nursing facility. I want to spend a minute or two just kind of taking a little bit of a 30,000-foot overview of, you know, why there's this kind of discrepancy in where post-acute care happens in the United States. This is an old slide from 2009, so it's, you know, 10 plus years old at this point. But this was a study done by the RTI that kind of came up with this conclusion that the choice of the post-acute care provider is determined by what is available, not what is ideal. If you look at this map, and I realize it's kind of small, probably even smaller on your small computer screen than it would be if we were blowing this up in the big classroom of the Hyatt. But all the little blue dots on this map are skilled nursing facilities. There's 15,000 of them in the country, compared to inpatient rehabilitation facilities, which are the black dots. where there's about 200 rehab hospitals in the country and about 1,800 to 2,000 rehab units, hospital rehab units within hospitals. So depending on where you are in the country, there may or may not be an IRF, inpatient rehabilitation facility, anywhere near your vicinity. I can tell you, I practiced in Columbia, Missouri for quite a while, and we were the only inpatient rehabilitation facility within 100 miles of that particular town. So the availability of inpatient rehabilitation facilities is variable across the country, and often the choice of post-acute provider is determined by what's available. The other thing that's happened, and we'll see more of this in a second, is that there have been a trend in the amount of physiatric, physical medicine rehabilitation encounters by site of service. Most rehab patients in an inpatient rehab facility will see a physiatrist. They'll be probably the attending physician for that patient going through rehab in an IRF. However, what's been happening is that the number of PM&R encounters has been going down steadily since 2004. It's somewhat leveled off between 2013 and now. But the number of physiatric encounters in a skilled nursing facility has been going up, as you can see by this slide, that over the period of time, that the number of inpatient rehabilitation encounters has gone down in IRF, but has gone up in SNF. But still, most people undergoing a rehabilitation program in a skilled nursing facility today in America will not see a physiatrist. They'll actually have their rehabilitation just performed by the primary care doctor with the therapy team, and then they'll be discharged. Why is that? What's fueling the movement of rehab patients to subacute? CMS and their infinite wisdom came out with a 60% rule that essentially guided what types of patients could go into inpatient rehabilitation facility, and that rule has restricted some non-compliant patients from being able to get their rehab in IRFs. Local coverage determinations also can specify subacute rehab for certain diagnoses. We see this in particular for orthopedic diagnoses, but also for other ones nowadays as well. Medicare Advantage managed care plans are managing risk and cost, and private insurers may direct the site of care to post-acute care for a SNF for some diagnoses. And in some cases, subacute rehab has been shown to be less costly for that particular diagnosis. So in orthopedics, there are several studies that you can point to that show that that subacute rehab, a SNF level of rehab, is more cost effective than an IRF level of rehab. And there's some back and forth, probably some debate about that, but I think that in general, you could point to the fact that skilled nursing facility rehab can be less effective for certain diagnoses. Subacute providers have been recognizing the need for physiatry-directed short-term rehab programs in a SNF environment, and that's also been fueling this movement. Here's a study that I want you to look at. This is an old slide again. This is from MedPAC, who advises Congress on Medicare. And basically, this study looked at the cost of taking care of patients with various different types of problems in various different settings. And so across here is skilled nursing facilities, IRFs, which are inpatient rehab facilities, and long-term acute care, which we're really not going to talk too much about today, but is another level of care where people might be getting some rehabilitation. So I've showed this slide many times before, and if you really think that a tracheostomy patient with a vent is going to cost $115,000 in a long-term care facility, but only $10,000 in a SNF, I think you're really comparing apples to oranges, because unless this patient came into this SNF and died within a couple of days, chances are they didn't cost that much less than being taken care of in an acute, a long-term acute care LTAC facility. So some of this is comparing apples to oranges. So, but I think if you look at something like joint replacement, you might say, well, the joint replacement patient that had to go to an LTAC and probably had a lot more other medical issues going on. They probably, even if they cost $67,000 in that environment, it's really not fair to compare them to going to a SNF. But you could probably compare the inpatient rehabilitation facility to the SNF for a joint replacement or a hip fracture and say, yeah, it is more cost effective to take those types of patients into a skilled nursing facility. So One of the things that we're looking at, again, this was information that was shared with Congress about comparing the different levels of care in terms of um, how it's less expensive to rehabilitate people in a skilled nursing facility. It may or may not be, this simple. Is I guess my point. But changing gears a little bit. So what is the physiatrist role in a SNF? We talked a little bit about this. Oftentimes we're asked to come in and address pain issues that are limiting function. If your patient's having pain in the skilled nursing facility, they're probably not going to be functioning at their best. It might drive up their length of stay, things like that. We're going to be looking at things like maximizing their functional status and understanding what function is possible given the patient's diagnosis and their condition. We're going to be looking at reducing overall cost to the healthcare system. Uh, that's part of our role. We're going to be right-sizing the length of SNF rehab stay and maximizing improvement per day. We're going to be reducing hospital rehospitalizations. And I'll show you some data coming up in a minute or two about that. We're going to be addressing patient questions about their disabling condition. Oftentimes one thing I found in my career is that patients are experiencing a disabling condition for the very first time, and they have no idea, and their family has no idea what's going to happen to them. It's very concerning to them. It's very troubling. And so if we go in and we know they've had a stroke or they've had something happen, and we can tell them they've had an amputation, we can tell them, hey, look, it's not the end of the world. We're going to work you through this. We're going to get you to a point where your disability is going to be minimized, and that helps them. So it also helps improve patient and family satisfaction for them to understand what's going to go on in their rehabilitation. We can assist in reducing barriers for their discharge home. And in fact, I want to make a point that the patients that we want to see are the ones that are going to be discharged home. I'll talk about that in a subsequent slide. And we can also be an advocate for patient when it comes to appeals, an advocate both for you, for the facility, and for the patient. Now, in terms of consulting PM&R for patients, what I would anticipate and what I think most physiatrists would anticipate is that you would consult PM&R when you have patients with impaired physical or cognitive function that are in active rehabilitation. So, and you notice that I use the word patients. I don't use the word residents necessarily. And you hear residents a lot of times being used in skilled nursing facilities. I think that we've entered an era where we have short-term rehab patients that are coming into skilled nursing facilities, and the anticipation is that they're going to get an active rehabilitation process, and they're then going to go, subsequently, they're going to go home, just like they would in an inpatient rehab facility. Maybe not quite as intensive a program, but they're going to be there, especially where you have need for coordination of a multidisciplinary team, and especially for those where the anticipated destination for discharge is home. More and more today, you're having skilled nursing facilities that want to differentiate themselves. They want to have specialized rehab programs. So you might have a facility that has a spinal cord injury program, a traumatic brain injury program, a cardiopulmonary program, a stroke program, one that specializes more in orthopedics or LVADs or cancer, those types of things. When you have those types of specialized programs, I would say, my argument would be that you need a rehabilitation specialist to help direct that particular area. Where there's reduced function of the patients due to spasticity, focal or generalized weakness, loss of sensation, pain, cognitive issues, you have these patients in your facility, and those are issues that we can certainly help address. When there's specialized adaptive equipment or DME needs, prosthetics, orthotics, specialized wheelchairs, or powered mobility devices, or other specialized adaptive equipment needs, that's our specialty. So we can certainly help you with those things. When pain management issues come up, particularly musculoskeletal pain, including but not limited to medication recommendations, therapy recommendations, joint injections, things like that. When you have patients who are at risk of falling or who fall, oftentimes we can help to assess why the patient has fallen. We can take steps to mitigate their falling. Even the act of having them actively participate in rehabilitation become stronger clearly helps mitigate their fall risk. So those are things that I think we'd also like you to be aware of and be thinking of consulting PM&R when you have patients like this. So you might say, well, what's the difference between, I have physical therapists in my building. What's the difference between having a physical therapist and having a physiatrist? Well, while we're not physical or occupational or speech therapists, we do speak the same language. So our training in physical medicine rehabilitation exposes us to these types of therapies and what the therapist can do. While we're not actually performing the therapy ourselves, we're actively discussing the patient therapy in detail with your rehab team. And so we're speaking the same language. We know what the types of therapy are that are available. We know how much therapy is needed for the patient to reach their goals. And those are all things that we're going to be able to help the team to assess and to deliver. So the other thing that I'll mention is that, of course, we are medical doctors and we can sign things like the Medicare certifications for therapy. We can write specific orders to the nursing staff, something that you as a medical director may not be as familiar with, say a bowel program that needs to be written for someone, or a bladder program, a dysphagia program. Those might be nursing orders that we can help you out with. Medications needed for rehab problems such as spasticity or pain, DME, appropriate outpatient rehab programs. We know the spectrum of inpatient to outpatient rehab. So what can be done in home health versus, say, an outpatient therapy versus, say, a day rehab program, that might be something that we're going to already have some familiarity with and can help you out with, even sometimes where the therapist may not be as familiar with all of the full spectrum of what rehabilitation options are available to the patient after they discharge. I want to spend a couple minutes just talking about, is there evidence that the physiatrist provides value to a SNF? So this is a study that actually was presented last year at the meeting in Atlanta. I had a poster. It was actually, the abstract was published in AMDA. The reference is down there on the bottom. But basically, we did a study where we looked at, this is nationwide. So this is taking all Medicare patients who had a physiatrist visit versus those who didn't in a skilled nursing facility. And I won't go into the details, but just to, if you want the details, you can go look at the abstract and the poster. But basically, we showed that 30-day emergency department visits were lower when we had an IRC physiatrist in the building. That the risk-adjusted length of stay was lower. You might say, well, that can be good and bad. The facilities don't necessarily want a less of a length of stay, but if you look at the subsequent, also going with it, the resource utilization group, of course, this is prior to PDPM, the resource utilization mix was higher for physiatry patients, which makes sense. These are patients that are more complex, they have more issues going on. So the facility is taking a higher complexity patient, they're delivering an outcome in a lower length of stay time. And then also we showed that our 30-day hospital readmission rate was lower than not having a physiatrist in the building. This is a slide, I'm sorry, it's kind of busy and probably kind of small on your small screen, but basically just showing that, again, an older study, 2012 to 2015, showing that during this time period, skilled nursing facilities that took a higher intensity, more complex patient and delivered them in a quicker amount of time to their discharge destination did better financially. You can see here that their total margin was higher for these patients with a lower length of stay. So this is a study that we sometimes bring out to facilities that ask that question. Hey, you're going to get my patient out of here quicker. I don't necessarily want that. We say, well, yes, but if you're more efficient, you're actually going to do better on your bottom line. And so I think that's something that we sometimes take to facilities and say, you'd like to be more efficient. And they go, yeah, we actually would like to be more efficient. We'd like to have higher turnover of patients in beds. We'd like to, take higher acuity patients and be able to provide them with a good program that does a service for them. Another way of looking at this, another way of spinning it, this is more local data that we have working with the Northwestern system here in the Chicago area. This is a study that Northwestern did. We were participants in it, but we were passive. We didn't really have anything to do with it other than practicing the way that we normally practice. But they looked at a control group, Integrated Rehab Consultants, physiatrists versus a competing group of physiatrists. And what they were able to show was that compared to the control group, our length of stay was lower compared to both the control group and the competitor. and that our hospital readmission rates were lower than the competitor and about the same as the control group. But it does also, show the process that I was saying before, that having a physiatrist is providing these types of level of value to the facility. Now, jumping forward to PDPM, PDPM is fairly new and we still don't have a lot of experience with it, but one of the things that we do know about PDPM is that facilities are using the patient characteristics to drive their facility rates for patients, including rehab patients. So what's the evidence that a physiatrist provides value to the SNF when it comes to PDPM? So on the left-hand side of this graph, you see just using the hospital discharge diagnoses for an orthopedic patient, hip fracture with routine healing, the daily rate in this case, and this is all based on a number of assumptions, including the region and other things that, you can't say this is the actual daily rate for a facility, but it is an example of one. That in this scenario where the physiatrist was adding some codes, some ICD-10 codes for poor balance and documenting those for mild dementia and some wounds and other codes that added into the nursing complexity, that all of a sudden the PDPM payment, where it had been based on the hospital discharge diagnosis alone, was $554 per day. It increased to $630 per day when the Physiatry ICD-10 codes were added into the mix. So facilities appreciate all the ICD-10 codes that they can get today under PDPM because it starts to add to their complexity of the patient. So facilities that are trying to navigate PDPM, we created a service where the facilities can obtain a list of all ICD-10 codes that are used by our physiatrists in their buildings. And it's a secure HIPAA compliant website where the facility can get access to only the patients that they have in their skilled nursing facility. And they can use that information to then appropriately code their patients under PDPM. And the constellation of ICD-10 codes will help describe patient nursing and therapy needs and lead to an appropriate payment for the facility where they might have been missing some of these characteristics of the patient in the past. There's a reference here that you can find more information if you're interested. So you might say, well, what is the cost of the SNF? Well, our company at least doesn't charge the SNF anything. That's not necessarily the case for all physiatry companies, but we believe that it creates the best value. We work off of the professional fees alone. We recommend that you place a standing order or use of an order set for short-term rehab patients to consult physiatry. Now, this has been probably one of the most contentious things that I've seen going into facilities. Medical directors sometimes say, well, we don't want to, or we can't create a standing order for physiatry for short-term rehab patients. The fact of the matter is you can. While you can order physiatry consult on a case-by-case basis, we have found that that slows the entire process down and delays us seeing your patient, potentially increasing your length of stay unnecessarily. So if I had one plea to make to you today, it would be that, think this through. If you're going to have physiatry in your building, make sure that they can see your patients in a timely fashion. That often means essentially saying, if a patient comes in on our stroke protocol, let's consult physiatry for that patient. If they come in on an orthopedic protocol, let's consult physiatry for that. It doesn't mean you have to consult physiatry for all patients. In fact, we don't want to see all patients. We want to see the ones that are appropriate for us to see, the ones that are short-term rehab, where you're anticipating the patient is going to be discharged home. And we like to see those people as soon as we possibly can. We recommend adding the physiatrist's name to the list of treating physicians in the case. This, gives us entree to see the patient. We request that the facility notify primary physicians and ensure their support and approval. We've gone into, trust me, we've gone into many buildings where that hasn't happened. The communication has not been there between, say, the medical director and the rest of the attending physician staff. And that's uncomfortable for us. It's uncomfortable for everybody because we want to make sure that the attending physician who is admitting the patient to a skilled nursing facility knows about it and supports the use of physiatry in the building. Then our providers will see the patient, will bill the payer directly, and for our services. So another question I often get asked, I'll anticipate it. Won't that interfere with my billing as a primary care physician? So the answer is no. IRC physiatrists bill for their services, which is different than what the primary doctor does. We're considered a co-treating physician, just like if you brought in a cardiologist, an infectious disease consultant, or a wound care doctor. They're not taking anything away from your billing. We're providing diagnostic codes that are not likely to be the same as yours, and our billing is identifying us as a medical specialist in PM&R by the specialist code that goes in with the billing, not as an internist or a geriatrician. So the answer is no. We've not seen any examples where somebody has said, when I have a physiatrist in the building, my bills are not getting paid. Do you have to be a physiatrist to be a good rehabilitationist in a SNF? So my answer to that is no. If you're a geriatrician, I know many geriatricians that are really, really good rehabilitationists. Because of geriatrician's training, you also will consider the overall function of the patient in his or her environment as they age. And so you might be asking rehabilitation-focused questions like, will this person be able to perform their ADLs without any help after discharge, or what help will they need with their ADLs? Could she become more independent with more therapy? What's the home environment like? Are there architectural barriers, stairs, rugs, things like that that I need to think about? Is there adequate family and social support? What about transportation needs? What community-based services might be useful to reduce the risk of readmission? Those are all really good rehabilitation questions that often are asked by geriatricians all the time. But I'm assuming that if you're a geriatrician and you're also the primary care doctor for someone in a SNF, and that person today is much more medically complex than they were, say, even 5 or 10 years ago, that you might not care to ask all those rehabilitation-focused questions regarding functional status and be able to develop effective treatment plans for them at the same time as you're also addressing all the medical issues. It might mean that you have to pay less attention to the medical issues for your patient if you're trying to do all these things. It might mean that you have to identify in the day of PDPM, that you have to start identifying all those rehab-related ICD-10 codes and coding for them and documenting them. It might mean that you have to attend rehab meetings, which take up some of your time and, trust me, are not reimbursed adequately by Medicare and other payers. It might mean that you would end up having to delegate your authority on length of stay or other rehab issues to the team because you feel that you may not be able to, know exactly what the endpoints, the outcomes are supposed to be. It might mean that you have to understand all the nuances of a good rehabilitation practice, and might mean that you have to do more updating of the patient and family about the rehab, sign certifications needed to justify rehab services, and deal with denials and peer-to-peer appeals for rehab services. Those are things that as a primary care doctor or a geriatrician, primarily concerned with the medical issues of the patient in the skilled nursing facility environment, you may or may not want to do. And so this may actually push you to having a physiatry consultant. So if that's the case, then my thrust of my argument here is to consult a physiatrist, have a rehabilitation specialist manage that patient case with you. And I would say that you will then should have the advantage of having better functional outcomes for your patients, lower cost overall to the system, higher patient satisfaction, and higher facility satisfaction. So with that, I will show you my bumper sticker and I will then pass the baton on to Dr. Azlan Tariq, who's going to give you a little bit more of the nuts and bolts of how this all works. There you go. We got his slide up there, and I will turn it over to Dr. Tariq. Thank you, Azlan.
Thank you, Steve. Great presentation. Thank you for the attendees. I'll see what I can kind of fill in. There's a lot of stuff that Steve talked about that kind of overlaps with my presentation, but I want to go into more the nut and bolts and that kind of stuff. So one of the things that I was thinking about before the presentation is, why are the attendees in this presentation here? Either you're interested in what PM&R is, maybe you've have a physiatrist on your staff at the facility, or at the corporate level, they've decided that they need a PM&R in the facility. Maybe you've seen the number of visits that PM&R is doing across the country going up, so this hopefully one of those reasons. But even though this presentation is somewhat self-promotional, and I have no qualms about that, but I feel like we have a branding issue. PM&R does, Physiatry does, just like palliative medicine a lot of time does, that people just don't know what we do exactly. And hopefully I'll go into a little more detail about that. I'm the Chief Clinical Officer for IRC, the largest group in the country, but at the same time, like, this is for all PM&R specialists. You know, I want to promote Physiatry in this setting, not just our company, obviously. My objectives hopefully will be describe the role in more detail, typical training. That's one of the big things that I want to discuss, and talk about the barriers to care before PM&R involvement and the typical scenarios and some of the clinical scenarios that we'll talk about. So residency. So after finishing medical school, obviously as a DO or MD, you go to PM&R residency. It's a 4-year program. The first year is internal medicine or intern year. It could be surgical, it could be non-surgical, but majority of us end up doing an internal medicine heavy year with time in the ICU and things like that, because we know that majority of the residencies actually are very internal medicine heavy in the first couple of years, and I'll talk about that in a second. But the whole residency is broken up into many different sections. We spend a lot of time at CVAs, strokes, different types of strokes, hemorrhagic and ischemic, and also different settings. So in my program, we would work in the ICU, we work in the ER sometimes to manage patients right off the bat. You know, in the acute rehab, and obviously subacute rehab, then outpatient. So you're pretty much seeing all the patients with the stroke diagnosis or brain injury diagnosis throughout the length of stay or throughout their continuum of care. Then you spend a lot of time with traumatic brain injury, with managing anything that comes along with that, spinal cord injury, orthopedic rehab, pain management, any kind of neuromuscular condition, some examples being MS, ALS, and Parkinson's. A lot of us end up actually spending a majority of the end of the residency in musculoskeletal medicine, and you know, we manage sports, athletes. Doesn't matter if you're a weekend warrior, it could be someone who's an Olympic athlete. Geriatric rehab is a big part of it. Obviously, there's a lot of overlap in this. We spend a lot of time with pediatric rehab as well. That's something that most people have no idea that PM&R does. We do injections, and there's many different injections, and I might go over them later on, but they could be joint injections, epidurals, Botox, nerve blocks, and things like that. EMGs, that's a big part of our practice. With us in neurology, we probably do the majority of the EMGs in the country. Prosthetic orthotics, that's a big part of our training. So we learn exactly what type of brace you need. We help build the braces, we help modify them. We train with gait analysis, things like that. And on top of that, a lot of us end up doing additional fellowship training. So you end up doing 5 years of this. So a lot goes into the training in PM&R, and the vast majority of doctors that I've talked to and we've done surveys on just don't understand the breadth of the knowledge that PM&R brings with them. With my own background, after finishing residency, I did a fellowship in musculoskeletal medicine and pain management, with a lot of times academic. It was a lot of time spent in palliative setting and acute pain control and pediatric pain control as well. So one of the things that I want to bring up here before I forget is that we actually spend a significant amount of time, and I'm talking about, you know, a couple of months or more, working hands-on with physical therapists. We actually are not the ones doing therapy, but we are with them as part of our rotations. We actually teach them and they teach us. We do anatomy with them, and that's all part of the training that we end up doing. And as far as fellowship is concerned, so many different types. You know, there are pediatric pain management, brain injury, palliative, neuromuscular, spinal cord, sports medicine, stroke. I mean, EMG, MSK, cancer rehab is a big one now, occupational health. There's a ton of fellowships out there. A lot of us end up doing fellowship, but if you come out of residency, and majority of the doctors want to do acute rehab or want to do you know, subacute rehab, for example, they really don't need a fellowship, but a lot of us end up doing fellowships anyway. The most recent data that I have is we have close to 1,000 physiatrists in the country, and from what we know from our data collection, there's close to 1,000 that are working in the post-acute setting. Now, some of the things Steve already talked about, but I'll see if I can go over some of them. So one of the issues when I started practicing the post-acute setting about 8 years ago was, you know, the first thing we noticed was the staff and the nurses have a lack of rehab knowledge. They really don't understand function. You know, that's not part of the training. They don't understand contracture prevention. They don't understand pain management issues, and you know, therapy at that point back in the RUG score level, you know, everything was being maximized, and they really didn't understand what the value of when therapy should be started, when it should be ended, and how it should be optimized. There was significant overutilization of medication, especially in our population with the NSAIDs, narcotics, hypnotics. That's gone down significantly, thankfully, but at the same time that was happening. A ton of testing and imaging being done for things that might not need to be done, x-rays for knees when there's no trauma, no fall, things like that. Lack of cohesiveness between families, patient, therapist, primary care team. The number of times I've heard families talk about the fact that they have a diagnosis, but no one talked about the prognosis or what happens next versus like, well, you have to go to the next level of care now. Delay in providing specialist care. Typically in the setting in which, we don't have a physiatrist, someone has knee pain, by the time they end up seeing an orthopedic surgeon, for example, or someone who does knee injection, for example, it could be weeks or even longer sometimes, but there's significant delay, not just in that, but other conditions as well. Inconsistent success with peer-to-peer. I've had colleagues who work in the post-acute setting and they're internal medicine or geriatrician, and they are frustrated with the peer-to-peer because a lot of times it's not a peer they're talking to. And at the same time, they're not really able to understand or let's just say explain the functional issues the patient is having versus the medical issues are easier for them to explain, but the functional stuff is the tough part. Then discharge to the hospitals due to peer-to-peer, due to pain conditions or different conditions that could potentially be taken care in-house. And also frequent outpatient orthopedic pain management appointments, especially in the COVID time now. We can minimize those things by keeping things in-house. Hopefully I'll talk a little more about like how my practice has changed since the crisis has hit. But at the same time, if we can minimize the patient leaving the facility, staying in-house and managing things in-house, it reduces the risk of further worsening the crisis. So what is a typical physiatry model? We're co-managing the patient. I'm not the primary care physician. I have absolutely no desire to be a primary care physician, and I make sure that the primary care physician understand that and know that I'm not going to do anything that's going to make their life more difficult. I don't want them to get phone calls about orders that I might have placed and be confused and concerned about that. I know that's a pretty common issue that, and again, because we're a specialty that is across the country and nothing is kind of organized in a way that we all practice the same way, people have different relationship with the physiatrist that they have. But my practice is that I have my own specific role. The primary care team understands what the role is, and they try to maximize that role, and I try to maximize that role. The frequent communication with therapists, that's common. I pretty much talk to my therapy director on a daily basis, or I have access to them. I attend the Medicare meeting if in a number of facilities that I have, and basically I am using the knowledge that I have from the internal medicine side and what the primary care team is doing, the therapist is saying, the family, the social worker, and combining it all together to tell the team itself what the potential discharge plan would be, what is the best case scenario for the patient's progress. Recognizing any barriers to care and rehab, and that's something we're really good at. We're good at basically fine-tuning things and finding out what the reason is if you're not at your optimal self, and communicating with the primary care team. Now, the primary care teams, one I'm going to talk about it as a side thing here. When I did my residency, we had in acute rehab setting, we had an orthopedic unit. This is in 2008, and while I was in residency, that unit, the ortho unit in our acute rehab, shut down. Then I started doing subacute rehab in 2012, and our ortho unit in the subacute unit just shut down recently. So the point is that the patients are obviously getting sicker, the case mix is changing, the acuity of the patient is changing. So having all hands on deck to help the patient out early on makes a significant difference in their prognosis. One of the barriers was reduced delaying in receiving pain medication. The number of times that the patient gets discharged from the hospital and they don't have pain scripts, or the primary care might not be comfortable in managing significant high doses. And not every physiatrist does pain management. That's a common misconception. Majority of us are used to it. We get trained in it. That's a big part of our training as well. But depending on the area, the practice style, we might not be. In my practice, because I'm also pain fellowship trained, I am absolutely comfortable managing any kind of pain. It doesn't matter if it's cancer pain or it's orthopedic pain, or it doesn't matter what it is. And I don't mind managing fentanyl, and obviously I'm not putting patients on that except with cancer, but at the same time, I'm okay with managing it. But the delay in receiving pain medication can significantly reduce the satisfaction the patient gets from receiving in the facility. And then the primary care team typically is more concerned than I am, because of my specialty, about risk and liability. things like that, and refills and what happens, you know, I don't know how to manage this and that kind of stuff. So basically, I'm able to help with that. Typically, I'm rounding on patients, rehab patients twice a week based on, again, medical necessity and rehab needs. If someone is absolutely stable and doing well and things are going well, I'm probably not going to see them that often. I might discuss with therapy team what's going on with them. At the same time, if someone is not progressing well, it's best for me to see them early on and find out the barriers to care early on versus later on. At the same time, the barriers to care might be more internal medicine issues. Now, being a physician, having trained in the acute setting for years, I can identify certain things that could be brewing. For example, a mental status change, or it could be increase of edema in the lower extremities, or things like that. So I'm able to kind of catch on that early on, tell the primary care team, hey, good idea to kind of run some labs, or this is what I'm telling you, it's up to you what you want to do, but this is someone you want to see early on to help this before an overnight call for discharge to the hospital. Available to help with patients at other level settings. So in my practice, I can still go to assisted living or long-term care patients and still help them out. And again, I'm not going to see them that often. I might start therapy for them. I might be able to do injection, maybe change their medication, but I'm able to help them, you know, spread out the care. And signing therapy orders if needed, that's a big part of it. You know, there's enough stuff to be signed during the day. If it's one thing that a physiatrist can do is sign therapy orders, because we are the best at recognizing when someone might or might not need therapy. So a quick poll here. So working with physiatrists in my facility, I'm concerned about. See if anybody can. All right, I think should be enough time. All right, so that's pretty expected. That's what I usually see, and you know, because we're across the country with 160 of us, with quite a few hundred facilities that we work in, but that's a very common issue that we hear about. And I know, like Steve talked about a little before, but I'll see if I can break it up in more. But definitely, I do want to talk a lot about the overutilization of resources. You know, at the same time, we'll talk about the not getting paid for services. So go to the next one, please. All right, thank you. So billing, Steve talked about a little bit as well. You know, we're working in the fee-for-service, you know, model at this point. Obviously, that's going to change in the future when you have a single, you know, payment for all acute setting or acute you know, diagnosis. But at the same time, with us, you know, we're not billing the same levels that typically primary care team is. That's for sure. You know, we're not billing 93110s or the highest level. We're usually at the lower level of billing. On top of that, if I bill someone on the same exact day as a primary care physician does, I have a separate NPI number, separate specialty. I'm using absolutely completely different diagnosis codes. You know, I'm not going to use CHF or COPD and things like that for my diagnosis. It's mostly orthopedic issues or rheumatological or MSK issues that I'm diagnosing and billing. At the same time, you know, our number of visits, you know, if you think about it, typically if I'm seeing a patient 1.5 times or twice a week and they stay for 4 weeks, I might see them 8 times total. And if you know the reimbursement of these different codes, understand that's a very small piece of the pie of a typical, let's say, hospitalization to the, you know, or overutilization of therapy or you know, length of stay and things like that. So the overall our data we've actually collected, you know, the cost of PM&R is very, very, very minimal considering everything else that happens. So if I'm taking someone off their pain medicine, if I'm getting them to, you know, do more therapy so they can go home earlier, those all things are cost saving. Overutilization of resources, this also, you know, understandable why someone would say that, but at the same time, you know, our goal coming in as physiatrists is to reduce the length of stay, is to reduce the rehospitalization, is to minimize the barriers to care. And that typically ends up causing underutilization or actually ideal utilization of resources. A liability is very minimal because we're independent. The facility usually has a contract with us. Obviously, the primary care physician has to sign off, and the fact that PM&R, you know, is going to be helping my patients out. But otherwise, liability, if anything, goes down, because now if I'm managing the pain medicine, that's one less thing for you to worry about. Very understandable. So I'm going to go through the cases. Each of these cases, the diagnosis in each of these cases, honestly, could be, I could spend 30 minutes on each to talk about, but I want to talk about some examples of where PM&R was able to help out on patients. And we've seen all of these cases. So first case, 67-year-old with frequent falls attributed to weakness and accidental falls and being clumsy. And this was, you know, discussed in the acute hospital setting. You know, Obviously, us as physiatrists, we are specialists in MSK and neurological examination. We spend a ton of time in this in training and obviously doing after that as well. And our exam is very, very comprehensive. We go through every single neurological exam you can imagine, MSK, range of motion, palpation, laxity, and things like that. So it is very, very common for me to find certain things that even typically other surgeons might miss because they're not doing that thorough an exam, or even other neurologists. But at the same time, therapists a lot of times will find these things as well. On a physiatry exam, patients found to have a left foot drop. And from in this case, what we found out, we'll talk about why a foot drop can happen, but in this case, there was a history of knee replacement. There's a correlation between when the foot drop started and it was right after the knee replacement. At that point, worked with an orthotist who basically provided a trial AFO, and the AFO was tried in the therapy gym, and the gait was analyzed to see if the right type of AFO was provided, then work on specific goals and give the patient the prognosis of how long will this last and provide further feedback on what kind of device you might need, and then go from there. So what are the causes of foot drop? And very, very common, obviously, is a pinched nerve in the back, a lumbar spine, L5 issue. It could be a damaged perineal nerve. Things like diabetes, ALS, MS, CVA. Again, this is a very, very big topic itself, but I want to kind of give you an idea that we are very commonly looking at these diagnosis lists when someone has a foot drop issue. Rare things like Charcot-Marie tooth or Parkinson obviously can cause it, but it's rare. Trauma, surgery, and also habitual leg crossing. Now, these are all things that I'm not saying this is the only causes. There's a whole lot more causes, but from my perspective, if everything else is kind of being ruled out, then I'm looking at these things. And then at that point, it is my job as a physiatrist to talk to the primary care team and tell them what the diagnosis is, tell them if further testing is needed. If it's something of a central issue, for example, a stroke that causes a foot drop or some kind of brain injury that causes a foot drop, the prognosis is usually poor for that versus a nerve injury or some kind of trauma to that side, which prognosis can be actually a little better. Now, treatment for this could be orthosis. Now, when I mentioned Botox injection in this case, the Botox injection is more going to be if someone has spasticity in a certain muscle that can potentially cause a foot drop, but that's really not normal. And therapy, what kind of therapy is needed, what kind of devices are needed at that point to help the foot drop. Again, we talked about prognosis already. Case number 2 is 59-year-old acute ischemic CVA now with left arm numbness and pain. Now, this is started about 2 weeks post-stroke. Increased sensitivity to any therapy or movement, so patients have a significant issue with any kind of light touch or any kind of movement. Now, typically, by the time I've seen the patient, the primary care might have already ordered some labs. They might probably did a Doppler to make sure there's no DVT, and they might have been able to try some kind of gabapentin or topical ointments, hopefully not narcotics. But at the same time, Tylenol is not helping with the pain, significant issues, any kind of range of motion is causing pain. So from the PM&R standpoint, we have training in this. Now, I'm not saying the geriatrician might not know this, but typically you don't see it as often as we would have in residency. So the diagnosis for this is central pain or central post-stroke pain. About 8% of stroke patients will develop this in the weeks or months after a stroke, and this usually is typically about a month or so after. And but it could be even earlier than that, or it could be even later than that. It could be 6 months after. Commonly prescribed oral medications for this are antidepressants, anticonvulsants, while opiates are really not the ideal thing for this. So stroke patients especially is not ideal. Now, amitriptyline is definitely not my first line for this at all because all the side effects that comes with it. But at the same time, if someone is not able to tolerate things like gabapentin or pregabalin, then that could be an option as well. Now, the idea is to increase therapy tolerance and to avoid narcotics. So if the pain is better, if the therapist can work on range of motion and to help hopefully prevent contraction development, it could be beneficial to the patient long term. Case number 3 is a 1-year-old with COPD and diabetes type 2 and recent onset of severe burning pain in the left thigh and hip. MRI in the hospital was performed and it was normal, and pain is causing significant difficulty in therapy. So from a primary care perspective, when someone talks about burning pain in this limb or the part of the leg, the thigh, you're thinking about most likely lumbar spine, and that was ruled out. And then you could be thinking about other nerve injuries, or you could be thinking about trauma and things like that. So, even though that could be part of the differential diagnosis, but I want to talk about a more unique case and how we can help out. And this is a patient with diabetic flexopathy. And again, I'm jumping a lot of things here because there's a lot more that goes along with diagnosing it, but at the same time, I want to give you a perspective. So also known as proximal diabetic neuropathy or diabetic lumbosacral radicular plexus neuropathy, is a tongue twister, and diabetic polyradiculoneuropathy. More likely in type 2 diabetic patients. The reason I brought this case up is because we have a lot of patients who have diabetes. And I've seen about 3 of these cases in the last 6 months, and all of them were not diagnosed. And I was able to kind of come in, help the diagnosis, get the treatment, talk to the family and therapist and the primary care physician, and kind of put them in ease that this will get better. So this condition, the treatment, it'll frequently improve with time and the body heals itself. And therapy and strict observation of blood glucose levels are very, very recommended. At the same time, medications may also help with the pain. So typically this kind of person should not be put on any narcotics or anti-inflammatories. It's ideal for them to do some kind of anti-congenital medicine. Again, really fast, but case number 4 is 85-year-old obese patient with chronic knee pain. This is a majority of our population. We have a ton of these patients. Recently worse, no evidence of fall, getting more therapy recently possibly, or just the weather. Injections, no evidence of fall, no recent injections, no recent history of gout. X-rays were performed by the primary care, shows severe OA. Therapy is limited because of pain. They're not able to tolerate any NSAIDs. You don't want to prescribe NSAIDs. You've tried the patches and things like that. Nothing is helping. But we know there's no red flags, no night pain, weight loss, fever, history of cancer, previous joint replacement. So from a primary care perspective, you're at a point now. Okay, so I've pretty much done everything. I don't want to put you on narcotics. Try to do what you can in therapy. But what does PM&R do in this setting? Well, our goal is to first of all diagnose the condition. Is it really OA? Is it something else going on? So we can kind of figure that out. Then we can talk to therapy and initiate modalities that are known to help with this. And you might have already done that with ice therapy and things like that. Now, some of us do this, some of us don't do this, but typically with my practice, I am doing joint injections in this population. Obviously, I'm extremely cautious about the amount of steroid being put in, how often and what is it used for, and discussing the family and the therapist and the patient. But the goal is for them to do therapy, and the risk and the benefit is weighed at that point. At that point, if a knee is aspirated and a cortisone or steroid injection is performed, that can significantly improve their pain and obviously take them away from having to take narcotics. I work with a orthotist, and a knee brace can be trialed to see if they can help with the stability of the knee, and a custom knee brace is provided at discharge, something easy for the patient to put on, and they can help with ambulation. And then typically outpatient follow-up can be set up with either PM&R, or it could be orthopedic or rheumatology or anybody else who does injections for potential injections in the future or nerve block. Obviously, a patient like the patient I talked about is probably higher risk, for knee replacement. So you do what you can to help them with palliative care. Case number 5 is 67-year-old female with recent right hip replacement, unable to return home as she lives alone. Post-op, minimal pain other than burning pain in the right lateral thigh. No neurosigns of weakness, reflexes or increased reflexes, so the exam is pretty benign, except there is focal sensation loss or reduced sensation across the lateral thigh. Now, what is this condition? It's called lateral femoral cutaneous neuropathy or myalgia parasitica, commonly known. Again, the number of times this has happened, and the patients have told me about the fact that the surgeon really didn't talk about it too much, or there was no discussion of how long it's supposed to last and it was going to get better, and the patient is concerned about something's wrong with my back, and this is going to happen forever and things like that. So what exactly is it? It's basically a compression of the lateral femoral cutaneous nerve right at the inguinal ligament. And why does it happen? It's as high as 81% of patients reported these symptoms after an anterior approach hip replacement. Now, obviously, we're seeing a lot less hip replacements in this setting now. Some areas you might be seeing more, but the elective stuff is going down unless they have complications live by themselves. But at the same time, the point is that 81% of patients will have this. Now, depending on the area, depending on the surgeon, some might do anterior approach, some might do posterior approach, but it's very, very common. So the goal is to tell the patient, this is what's happening. This is very common. It's not going to affect your function. This is a purely sensory nerve. It's not going to affect your motor strength. But just because he says purely sensory doesn't make the pain get better. It is irritating, and sometimes it can be debilitating. But only a small percentage have full resolution. They'll still have some sensation of numbness or lack of sensation in that area. But what Physiatry can do in this setting, or any physician, but ideally us, will be able to kind of get the diagnosis early on, reassure the patient, A lidocaine patch, not obviously on the incision or around where the nerve is, can help with the numbness because that's where the tract of the nerve is. And a low dose gabapentin ideally, can also help, but again, a lot of times it's more reassurance that helps the patient. A 69-year-old with chronic neck pain with recent exacerbation, x-rays show degenerative changes and disc space narrowing. Pretty much that's everybody who's 69-year-old is going to have some of those changes. On exam, no neuroscience, no radiculopathy, no red flags, no other concerns. Really taut band of muscles and bilateral scale, scalenes there, not scales, and trapezius muscles, so upper body here. And therapy limited due to pain, patients not able to move their neck around. Any kind of topical ointments are really barely helping. You don't want to put someone like this on narcotic or muscle relaxant. And the reason is that the condition is called myofascial pain syndrome. With advanced age, the prevalence of all kind of musculoskeletal pain increases by up to 40 to 50%. This is associated with posture, age, underlying arthritis. It could be the new mattress they have or the new pillow they're sleeping on or something they did in therapy. In this case, it's not, like I said, advisable to use narcotics or NSAIDs or muscle relaxants first line. The goal for PM&R in this case would be to optimize therapy use modalities. So it could be a heating pad, it could be things like biofreeze, topical ointments, it could be a patch, it could be some other patches like capsaicin patch. But what I typically do for these kind of patients, if the pain is extreme, would be do a trigger point injection. Now, a lot of physicians know how to do trigger point injections. It's basically using a thin needle and using lidocaine or a dry needle and injecting the taut band, or basically the point of maximal tenderness. Right after the point of the trigger point injection is not to give you significant relief forever. It's more for you to be able to do therapy afterwards. So there's going to be a protocol. So after the injection, therapist comes in, does stretching, maybe heat to break the pain cycle and to avoid any further testing or medications. Case number 7 is a 59-year-old with new onset left CVA with resulting right hemiparesis. Therapy limited due to tone. Very, very common for these kind of patients, obviously have tone, and tone is causing pain at night, unable to perform any ADLs due to pain. So therapists trying to move their arm, having difficulty doing that. So what is that? That's CV-related spasticity. Again, very common for us to see that, but spasticity is velocity-dependent increase in tone. It can improve with therapy if mild. It can be, if in moderate cases or severe cases, aggressive management to avoid contractures. And that's a very common, unfortunate thing that I see in my practice in Chicago and in Northwest Indiana as well, that spasticity wasn't treated early enough, and now it's a contracture, and therapists ask me like, oh, can we help you? Can you do anything with a contracture? When it's a contracture, it's usually too late. So it's best to treat that aggressively early on to prevent that from happening. The number of patients that I've seen who have spasticity and have never even tried baclofen. So it's something that you think about and do early on. At the same time, the physiatry teaches us that spasticity or tone can actually be good as well. So if you overtreat it and you make the limb too loose or too hypotonic, then that could be a bad thing. So the tone in the leg could benefit you for transferring and walking. So you don't want to reduce the tone all the way down as well. You can do a trial of baclofen. You can do outpatient Botox injections that are done more for focal spasticity, not for generalized whole body spasticity. Things like that, they need a baclofen pump and things like that. But we can help make that decision to find out who the best candidate for that is. Bracing is key. Hand splints, what type of hand splint, how often is it worn, hygiene that goes along with that, AFOs or braces, knee braces, elbow braces, like we understand, and we talk to the therapist about what type of brace someone needs. And again, one of the things that I'm looking at, as an eyes and ears, hopefully with the primary care team, is if I notice a sudden increase in tone, that could be something underlying. It could be infection, it could be a underlying UTI or a wound, or and obviously a patient could be grimacing and things like that as well. So those are things that I can ideally find out early enough and then let the primary care team know. A few more cases. Case number 8 is a gout, subacute, very common that we take care of this. A 69-year-old with new onset severe left knee pain, swelling, erythema, elevated uric acid level. At this point, primary care team probably did colchicine, maybe a Medro dose pack, improvement, some improvement, but not significant. What can PM&R do if Physiatry can do at this point? Very commonly I'm asked to see patients for this, and I can aspirate the knee, take the crystals out, give a cortisone steroid shot at that point, and the significant reduction of pain at a very quick pace versus, a lot of times other non-injection process might not improve so well or quickly. And then obviously review the medications and, what is the cause of this? It could be a number of things, obviously hydrochlorothiazide, things like that, and prophylactic medication started. Vertebral compression fracture, very common. Again, all of these topics should be talked about in a lot more detail, so I apologize for going through so fast. A 73-year-old female with COPD, chronic steroid use, obviously high risk for this. Acute onset of mid-back pain. The primary care ordered an X-ray, showed a compression fracture, but it's a compression fracture. What do you do next? No neuroscience. Family really does not want to do any augmentation, which can be very beneficial for acute fractures, can help reduce the pain, but the family doesn't want to go that way. So what do you do now? Do you just put them on narcotics, or do you just have therapy manage it? What PM&R that would do in this setting would be, first of all, get the right diagnosis. Look at getting a brace to help with the pain, or to kind of reduce the pressure in the back. Talk to therapy about the rehab precautions. What are certain things you can and cannot do? How much can you lift? How much can you twist? Now, calcitonin is a nasal spray that can be used for acute compression fracture pain. Randomized control studies have shown that it's very beneficial. Mild pain, pain meds can assist with something like tramadol, maybe Tylenol. And then obviously the goal of the patient is going to be, what is your prognosis? Will this get better? Do you need surgery? What is the long-term plan to help reduce this from happening again? Other examples, I've talked about bracing quite a lot, adjusting wheelchairs and mobility devices. So typically the primary care physician might just say, order wheelchair. We can actually manage exactly what type of wheelchair, how low, how high, how wide, what, the different weight components, what type of cushion, discussing prognosis of the family. A lot of times they ask me, am I gonna walk again? And the primary care teams that I work with, usually they're hesitant to talk to the patient about this because sometimes they just don't know what the prognosis is. But with us, we understand this part of our training. We get board certification with this to understand what type of stroke will, help you, or not, excuse me, help you, but the prognosis for a typical stroke is for brain injury, spinal cord as well. Contracture management, attending team meetings, fall prevention programs, or things you can integrate with physiatry and managing all narcotics. So again, I went through this really quickly. If you have any questions, please leave to the end, or you can put them in the chat box. Over to you, Wahab.
Hi, I'm Ashir Wahab. I've been asked to talk about the role of the primary care physician and how we interact and work with a physiatrist in the SNF. And I have no financial disclosures. And just to tell you a little bit about myself, been practicing now 22 years. The first 15 was primary care and going to a few SNFs. 7 years ago, I became full-time in Post-Acute. I was with IPC and then Team Health. Eventually, just worked in one facility, which is out in Munster, Indiana. And I've been there for about 5 years, and this is where I started working closely with Physiatry. Since then, just a couple of months ago, I did leave that job. Now I'm with Oak Street Health. They're starting to go into long-term care, and I'm the medical director for that. So while I was at the facility out in Munster, I had a skilled nursing facility, an assisted living facility, and memory support unit that I was in charge of. At that time, I started working closely with Physiatry. Before that, I really didn't have much interaction with them. They were in a few buildings previously, but never really knew what they did there, truthfully. So why work with a physiatrist? I actually have them see all of my patients when they come in the skills facility. I want them to eyeball them at least, and they do follow if they feel like they can help me. If not, then they just sign off the case. I do also see them and have them come into my memory support unit, as well as my long-term, my assisted living facility. Only when I really need them, I consult them, and it's more for chronic pain, or if I feel like the patient can benefit from an injection in like a knee or a shoulder. Otherwise, they routinely don't go there. So I have found that since I have them on board, I do have better rehab management and coordination. They are a good liaison between the orthopod and physical therapy. I've seen great success with them being in-house. They usually come into my building 2 to 3 times a week. They are always on top of things when I see them. We have a good collaboration, and I do make it clear what I want from them and what they want from me as well, and we do a good job there. Mainly, I like them because they do the pain management in my building, and I think that does go very closely with the rehab, and it makes sense for me, but also I don't have to worry about writing the pain meds and refilling meds. I don't get those calls at odd hours, so that takes a lot off of me. I appreciate them with the DME orders. They can really fit specifically the type of brace or what's needed. They work closely with the therapist in doing that. As discussed by the other 2 presenters, the rehab specific medications and nursing orders. I feel like that they do have much more insight in doing that. They've also been very outgoing and meeting with my patients and their families, talking about what the prognosis, what the treatment plan is. They go to the care conferences when asked, so I've been very happy with that. This has led to increased customer satisfaction, decreased returns to acute care. And I especially like them because they do these peer-to-peer reviews. I didn't realize they did that until a couple of years ago. It takes quite a bit of time for me to get everything together, talking to the therapist, the nurse, the family, the patient, and then calling up for a peer-to-peer review. So now I don't have to worry about that. I just ask Physiatry to take care of that. All right, if we can go forward, there we go. Are there any times when I wouldn't want to work with a physiatrist? There's only a couple of times I can think of. That would be probably the short stay patients, the patients that are coming in for a couple of days of IV antibiotics before they go home. Also, probably patients that are in for respite care. They're just there for a couple of weeks while the family goes on vacation. I don't really ask for a physiatry to see. Differences between a physiatrist and a physical therapist, I think that's been touched on earlier in this lecture, but of course education. The physiatrist is a board certified physician and able to administer injections and medications, and physical therapist is a 3-year degree with certification. I think the main thing that we have to differentiate is the role. The physiatrist can diagnose, treat, and manage musculoskeletal issues, while the physical therapist can only execute a treatment plan provided by Physiatry. So that's very important. So they're not making up the treatment plan. If we don't have a physiatrist in-house, it's usually the orthopod that they're contacting to get the treatment plan. So there's always someone that has to give these orders for them to follow up. And more importantly, also, they cannot diagnose medical conditions. So they really can't do any kind of a diagnosis. They can make suggestions. They can call up the docs or the providers and tell them what they see, but they really can't make that diagnosis. All right. Frequency of business, as I said before, they do an initial evaluation. My physiatrists are in the building, like I say, 2 to 3 times a week, and physical therapy is there every day. So that's how it's run in our building. That's a repeat slide. Have I noted any advantages when it comes to PDPM? I do know that since October, my patients have become definitely a higher level of care, a lot more CHF than I've seen in the past. I do feel like I myself am putting in the higher codes or different codes, but then the physiatrists themselves are putting in codes more on the rehab side that I probably wouldn't be thinking of. So I have seen increased reimbursement due to that. And I do believe that we have lower costs with more efficient care with Physiatry on board. A couple of examples of where I thought Physiatry really helped me. I got a couple of cases there. The first one's a 68-year-old female. She was day 2 status post lumbar spinal fusion. Surgery went well. I did my initial H&P. She said her pain was 4 to 5 out of 10, still in the low back, radiating to the legs like it was before surgery. She had some urinary retention. She had a Foley in, and I thought everything looked good there. I was more worried about her blood pressure and her sugars. So our plan was just to DC the Foley the next day for avoiding trial, and I thought everything was in order. Physiatry came in later that day, and the pain had gone up to 8 out of 10. And then they also noted a saddle paresthesia. They sent the patient emergently to the hospital where she had decompressive surgery, and she was diagnosed with Cauda equina syndrome. So I'm positive that that wouldn't have been caught that early. It would have been the next day at the earliest. So I was very happy to have them on board. The other case was a 72-year-old female admitted with lower extremity weakness and paresthesia in the hands and feet. Very pleasant lady. She was just falling at home. The family was concerned, so we put her in for some therapy. She was getting stronger, was actually doing well, was walking with a walker, going to the toilet, and actually ambulating in the hallway on her own. She's continued to have that paresthesia in the hands and feet. Her primary care doctor had talked to her about that before and trying some gabapentin or some Lyrica, and she was hesitant to do that. I asked neurology to talk to her a little bit more about this. They agreed that it was just a polyneuropathy, and she ended up taking gabapentin. 2 days after starting that, she had a fall, which we thought was due to the gabapentin, and that was discontinued, but she really never got stronger and actually was getting weaker. She is now staying in bed, was an assist of 2, and Physiatry had been following all along, and they were concerned with the change in status, and they suggested a more aggressive workup. I did an x-ray of the hips and the lumbar spine, and that was negative, but Physiatry didn't let that go and said that she needed a CT scan of her spine. We eventually did send her in, and she was diagnosed with significant cervical spondylosis. So that was an urgent situation. We sent her to the University of Chicago, where she had surgery. So those are the 2 cases that really popped out, and I do believe that having a physiatrist that's really been honed into trained and to look at things that we would probably miss was very important, having them in the building. They've also caught in several cases of foot drop, untreated neuropathy, myalgia due to statins. Those were the things that I would really seeing. So my takeaway is, if you're going to have a physiatrist come in the building, or you already have one, really talk to them, delineate the roles. My physiatrists know that they're the rehab side. They're not doing anything else except rehab, and I really feel pain control is part of that. If I have to do the pain control, then I'm doing the musculoskeletal exam. I'm doing everything else. So it kind of doesn't make sense to me. So that would be something that I would be asking as well, and always have a good relationship. Whereas they can always talk to you if they see somebody that's having increasing shortness of breath or some other issues, or their blood pressure was a bit higher when they went in, that they should be able to reach out to you and ask you to evaluate. And I do the same thing. If I'm going into a room that a patient's all of a sudden saying they have 8 out of 10 pain where they didn't before, I'm calling Physiatry or texting them to evaluate them. So I think a good relationship with your physiatrist is what you really need to do, and make sure that your goals are the same. So that's the end of my talk. I believe we're going to take questions now.
Thank you all for a wonderful presentation, and thank you to the attendees again. So we're now going to begin answering the questions submitted during today's presentation. So our first question here is, what are your thoughts on serving as a medical director and attending physician in a SNF?
Myself?
As a physiatrist, you're saying?
As a physiatrist, yes.
Some physiatrists do. I mean, I know that there are some that do. I don't know, Azlan, maybe you can comment on that.
I personally prefer not to. That's not my training. The patients are getting really sick. I don't have the internal medicine background or nutrition background that a lot of these, obviously our internists have. But if there's someone who's comfortable enough doing it, absolutely. I mean, I feel like back, you probably know, Steve, like we had a PM&R internal medicine residency. It was a combined residency back in the day, but I think they stopped doing that. But there are some physiatrists who are very used to managing acute rehab sick patients. But typically from our model, we don't plan on doing that.
Great. So our next question is, does PM&R consider becoming primary attending instead of a consultant in the SNF on selected groups of patients whose admitting diagnoses are under the neuro or ortho categories?
Pretty much same answer. It can happen because we are, medical doctors, but I think many of us in this space, really appreciate more the consultative role. And I think, the same thing would potentially happen to us if we became the primary doctor in the skilled nursing facility, is that, we might become overloaded just thinking about the medical issues and not being able to concentrate as much on the rehab issues. So I think that's why a number of us really appreciate, kind of the co-treatment model of having the primary care team there, as well as us then, being the physiatry consultation.
And to add a few things in the acute setting, quite often the PM&R physiatrist is a primary care physician, obviously, but they have internal medicine, hospitalist consultants that help them. So it's a co-management model. I think it works best if you stay in your lane and kind of do what you're really good at and get people to help you, and no one need help.
Great. So the next question is, with a custom knee brace as well as a prosthesis for above the knee amputation, it can be very expensive, and the concern is that the skilled nursing facility would have to pay for that. So what's a practical solution for that?
I can answer that if you don't want, Steve. So that's very, very common. It's really unfortunate this rule exists that you can only get the brace or the AF4 or things like that 48 hours before your discharge. So what we end up doing is I talk to my local prosthetic orthotic providers and have them give the patient a trial so they can actually use the brace while they're at the facility, and right before they're about to go home, they can actually bill the patient directly so the facility does not have to pay for it. There's some gray areas in which you kind of help the patient out. A lot of times the prosthetic orthotic companies will drop off a bunch of braces they have that are not used, for example, as a donation, and the patient can try them, different type of knee braces, different type of back braces that can be sanitized before use. But sometimes, unfortunately, the facility will have to pay for a specific brace. And if I have to kind of go in front of them and tell them like what the long-term reason for this is, that they're going to end up doing better, sometimes it works, but they're very expensive, without a doubt. Steve?
Yeah, I mean, that's my experience too. Back in the day when everybody stayed in the facility for 100 days, you could get an amputee through their, pretty much their entire wound healing and pre-preparatory, pre-prosthetic training before they went home. Today, you don't have that option, and you don't have that ability. That I think what I've seen is the prosthetic companies then stepping up and saying, okay, we'll provide you with what you need in terms of preparatory prosthesis that we don't have to charge for. We can then, charge the patient when they get their final prosthesis on the back end.
Okay, and Dr. Tariq, you had a question that you wanted to go ahead and answer.
Yeah, someone asked a question and it really wasn't super clear, but it was, I understand what the gist is. They're saying that, a lot of times the primary care physician, especially with the new era of the opioid stuff, they're fearful and they don't want to prescribe any narcotics. And would a solution for that be PM&R or physiatry in that case? I think yes and no, really depends on your physiatrist that you're working with. Some physiatrists really don't want to prescribe narcotics as well. I think with my goal, obviously you have a subset of patients that are the chronic pain patients that I cannot manage them, or the primary care cannot manage them in this setting. They have underlying psych disorders, psychological issues. They're on these long-acting or high-dose medications as outpatient. The subacute is not a chronic pain rehab facility. In that case, I'm just gonna keep them on this medication they're on, and then outpatient, they can go see their psychologist and chronic pain doctor. For the patients that have acute pain, fractures, post-surgical, things like that, I am relatively liberal about the medicine that I'm prescribing, obviously starting low and going slow, but all based on rehab. It's not based on just comfort. It's all based on, is that affecting your rehab and your function? That's my least idea about that.
Well, thank you all so much. And we don't have any more questions in the queue at this time. I'd like to give you each a chance to just give some closing remarks. So we can start with Dr. Wahab.
Okay, so my experience with physiatry has been positive, especially when you really delineated responsibilities and everybody's on the same page. Once again, also we need to make sure that the physical therapy departments agreeing with how things are being run as well. So it takes a bit of training with the floor nurses as well, just to make sure they know who to call when something's going on. But once that gets done, it really works well. I've been very happy.
And Dr. Gnatz?
Sure, I'd like to, again, thank everybody for their time and attention this morning. I think that hopefully we have reached our objectives of being able to impart on you a little bit of the more familiarity with what a physiatrist's role would be in a skilled nursing facility and what the value of that is. I mean, that's really the goal of our company. I think that in my experience, having grown up in the acute inpatient rehabilitation world and then transferring my practice into the subacute skilled facilities, people always ask me, well, how did that come about? And I just say, well, I followed my patients, because that's exactly what I did do, was that I was seeing the patients in an acute inpatient rehab facility 20 years ago. Now I could be seeing the same patient in a skilled nursing facility environment that was in an IRF 20 years ago. So I think that there's been this migration of patients across, and I believe that physiatrists can and should be following them into the skilled nursing facility setting, that we provide a lot of value in that setting.
And Dr. Tariq, any closing comments?
Well, I mean, yeah, hopefully I was able to relay to the attendees what the breadth of knowledge that PM&R brings with them. At the same time, it's important as a primary care physician or administrator to find the right partner, the right physiatrist, and find what the needs are for your facility and your patients, and seeing if someone can actually help with that. I think with the new era of Sub-Acute, obviously at this right time, the COVID crisis is taking over everyone's mind, but at the same time, the patients are still getting the rehab. They're still actually having the same issues that they were having before the crisis. So I'm still actively involved with all my patients. So, we still need to advocate for our patients. We need to find the best resources for them. And if that happens to be PM&R Physiatry to help you with that and take one thing off your table, then I think it's worth it.
Thank you all for a wonderful presentation, and thank you everyone for attending today's session. After we conclude, please return to this session's main page in Apex to complete an evaluation and claim credits. If you have questions, please contact AMDA at education@paltc.org. On behalf of AMDA, the Program Planning Committee, and our presenters, thank you for joining us today, and have a great rest of your day.
Thank you.
All right, thank you.
Thank you.